You able to get to the Slido?
Yeah, yep.
Right. So you're called by the access center about a patient at an outside facility down at Beloit, 60-year-old female, unilateral convexity traumatic subarachnoid hemorrhage, DAI, had been in a motor vehicle crash. The GCS is fixed. Her systolic blood pressure is 110 over 40. She's being intubated and getting Keppra. What BP parameters do you give the outside facility for transport? Nicardipine drip for SBP less than 140. Nicardipine drip for SBP less than 160. Levophed for MAP greater than 80. Systolic greater than 100. Nicardipine drip for less than 120, or even no BP parameters. Everyone get a chance to. So the consensus seems to be SBP less than 140. We'll go to the next slide. Same story. This is now a large unilateral subdural after MVC. The systolic blood pressure is again 110 over 40. And again, what BP parameters do you give? Nicardipine drip for less than 140, for less than 160, for less than 120. Levophed, no BP parameters. Kind of hanging on this less than 140 number. Again, now it's large bifrontal contusions after MVC. Otherwise, the parameters are the same. All the admission data is the same. What do we tell them? Again, I'm seeing systolic for less than 140. Does anyone want to say why they're saying that? What they're hoping with that?
I think that most people say interactive, Apache 2 for that.
Sorry?
I think most people say interactive, Interact 2, and Apache 2 for that, even though that was right. It's not an intraparenchymal hemorrhage, not necessarily trauma.
Yeah. So is trauma different than spontaneous? Yeah. And should we treat trauma different than spontaneous? I hope. In all of these situations, was the bleed arterial? In any of those circumstances, was it arterial? Is a contusion an arterial bleed? Is DAI an arterial bleed? Is there any spot sign for a contusion? Is there is an angiogram going to be positive for a contusion? Probably not. Lowering blood pressure parameters, lowering blood pressure for a venous bleed doesn't make a lot of sense. Very, very different pathophysiology. And treating it the same as an intraparenchymal hemorrhage will probably lead you in the wrong direction. Kind of going back to that unilateral subdural, hemispheric subdural has had the hemorrhage evacuated in the OR. The brain's not fungating. It's below the bone edge. You expect a long, difficult ICU course. This patient came in GCS 6. They're probably going to be in the ICU for 2 weeks. In terms of craniotomy versus craniectomy, do you attempt to replace the bone or leave the bone off for decompression and for expected swelling? Place an EVD, measure the ICP drop, and then decide whether to replace the bone. Right now, it seems to be leave the bone off for decompression for expected swelling. The hemispheric subdural had a craniectomy, is GCS 6 after the OR. Sodium's 138. What further management is indicated in the ICU? Place an EVD or ICP monitor, treat based on ICP. Start empiric 3% at 30 mils per hour. Palpate the scalp flap on rounds to estimate ICP and treat accordingly, or consult palliative care. Consensus seems to be place ICP, EVD, or ICP monitor and treat based on ICP. Your hemispheric subdural has been stable after the OR for 2 days, no ICP issues, EVD in place, and has not shown any evidence of reaccumulation. What should be considered to be started now? Biweekly lower extremity ultrasounds, heparin 5000 sub-Q BID, Lovenox, or a heparin drip. Seem to be favoring Lovenox. A 40-year-old male, severe TBI patient arrived GCS 4, had one reactive pupil, large subdural. The admit labs weren't really very notable. Hemoglobin 15, glucose 105. After OR and 7 days in the ICU, has normal flexion. So you do central stim and he does a little normal flexion, but doesn't actually localize. He's eyes to pain, he's intubated. The MRI shows grade 3 DAI. What's the 2-year median prognosis if no withdrawal of care? Is that the consensus? Seems to be conscious but complete dependence, a SNF resident. So today I'll be presenting some updates in traumatic brain injury. I'm going to go over some recent papers that have come out in this field, some older papers too. The idea behind this is to both educate everybody about developments in traumatic brain injury studies, but also hopefully update our care. That's my disclosure. So we'll be talking about subdural management, TBI blood pressure management, DVT prophylaxis, prophylactic hypertonic, intracranial pressure monitoring after decompressive craniectomy, and severe TBI outcomes. We'll apply findings from these papers to common types of cases. So last year, there was a publication in the New England Journal of Medicine from P.J. Hutchinson, who's at Cambridge, and his group on treatment of acute subdural hematoma. And they were able to get almost 500 patients enrolled in a randomized clinical trial of craniectomy versus craniotomy in subdural, which is pretty impressive to enroll that many patients for a surgical trial. The outcomes This was sort of enriched for severe TBI, but did include some moderate TBI patients. The main outcome was the GOSE Glasgow outcome score extended at 12 months. Comparing the GOSE at 12 months between the craniectomy and craniotomy patients, it's very, very similar. So about 2/3 of these deaths occurred in the first 2 weeks, were probably from withdrawal of care. And then at each of the different GOSE levels, pretty similar outcomes. The one difference that was seen is that in terms of further cranial surgery, about 15% of the craniotomy patients ended up needing a decompressive craniectomy. But about 12% of the decompressive craniectomy patients ended up having a wound complication, which makes perfect sense that patients that get decompressive craniectomies tend to have higher wound complications. And when the protocol had been announced several years ago, and the trial was closed at the beginning of last year. And when rumors of this data were sort of circulating in the TBI community, there was rumors that craniectomy patients had done much worse. And where I was working, we were even talking about placing cooling casts in these patients and doing anything that we could to avoid a craniectomy. But you can kind of see that in terms of outcomes, very, very similar. But doing a decompressive craniectomy in a TBI patient does expose them to the risk of wound complications. In terms of neurologic outcomes, needing that further surgery doesn't seem to particularly hurt them. So not doing the decompressive craniectomy up front doesn't seem to have worse neurologic outcomes. So at this point, the consensus seems to be that when you can, attempt to replace the bone flap. Certainly if it's under tension, if the brain is fungating, there's no reason to push it, but doing a prophylactic decompressive craniectomy probably isn't necessary. I would like you to all burn in your heads, burn in your minds these numbers. Pay very, very close attention to these numbers here. Memorize them. So blood pressure management and TBI. Back in 2007, Lori Shutter, who's the director of the Neuro ICU at Pitt, and Raj Narayan, who was at Cincinnati at the time and ended up becoming the chair at Northwell, published a guidance saying that the treatment of acute hypertension in patients with traumatic brain injury is not recommended. Cerebral perfusion pressure in patients with intracranial pressure monitoring should be maintained between 50 and 70. The most recent Brain Trauma Foundation guidelines has as a level 3 recommendation to maintain the systolic blood pressure greater than 100 for patients 50 to 69 years old and greater than 110 for patients 15 to 49. And that seems to be able to decrease mortality and improve outcomes. There was a recent publication out of the ER literature. They, interestingly enough, do some pretty significant TBI research, the ER community. And they were looking at the optimal blood pressure parameters for major traumatic brain injury. They have this EPIC study, which is kind of a registry-based study, but they were able to get 21,000 patients in that. In that group, they were able to have sufficient data for about 12,000 patients, which is pretty large number for severe TBI. And what they saw is kind of what was expected, that hypotension is associated with very, very poor outcomes. And, and then you see kind of an optimal level, 125, but in terms of the top end, you don't really start to get particularly bad outcomes until you get to 180 or higher. So having a tight blood pressure parameter, especially nicardipine drip, on these patients is probably not to their benefit. And instead, having a more liberal blood pressure parameter and specifically avoiding hypotension will be to the benefit of these patients. Another recent publication, this is out of World Neurosurgery on DVT PE prophylaxis. I particularly, from a evidence-based medicine standpoint, I don't like these kinds of studies, these TQIP studies that, oh, we'll look at this huge registry and try and come up with any conclusions. The advantage of these big registries is that for complications, it can be very illustrative. If you're if you're doing a randomized control trial where the outcome is occurring 15, 20% of the time, you can have a reasonable number of people enrolled. For example, in that decompressive craniectomy versus craniotomy study. But for DVT prophylaxis, it's very hard to enroll enough patients in a study to be able to have comparable, to look at outcomes. So in this study, they were able to get 215,000 TBI patients in their analysis. So in terms of the Lovenox versus sub-Q heparin debate, in neurosurgery, the fear is always, oh, if we start them on Lovenox, the hemorrhage is going to blow up. I'm going to need to go in and evacuate another hemorrhage on them. I can't reverse it. With sub-Q heparin, I might be able to get protamine. With Lovenox, I can't do any of those things. But in these two groups, which 156,000 on Lovenox, 62,000 on sub-Q heparin, there were lower rates of delayed cranial decompression for the Lovenox group, lower rates of DVTs, lower rates of PEs, lower rates of return to OR, all of which were highly significant. They did do a propensity match score. I think in terms of the quality of the analysis that reported both the gross statistics as well as the propensity match data was very helpful. But overall, they found that use of low molecular weight heparin in this group seems to be have improvements in primary outcome of intracranial surgery. So certainly it doesn't demonstrate that Lovenox is more dangerous than heparin. One number that I'd like everyone to pay attention to is the population. So in this group, which represented 3 or 4 years of trauma patients in the United States in the TQIP data, 156,000 were on Lovenox and 62,000 were on sub-Q heparin, meaning about 2/3 in the United States, about 2/3 of TBI patients are being put on Lovenox, about 1/3 on sub-Q heparin. I don't know, have you guys ever seen these adoption graphs that, you have I want to be the leader, I want to be the first in this, then, oh, I heard this from my friends, I'll sign on early. Then there's the pragmatists, like, oh, this seems to be working, I'm gonna kind of get on board. And then there's the conservatives, the people that kind of lag behind. And then there's the skeptics. And right now, in using sub-Q heparin in traumatic brain injury, folks that do this are somewhere here getting towards here. And the last place I worked, they used Dilantin for seizure prophylaxis in traumatic brain injury. And they were very early in doing that, doing seizure prophylaxis in traumatic brain injury. They stuck with it. They've done it for 30 years. They go to every national conference and argue, till the cows come home, that everybody should be on Dilantin, that the use of Keppra is just laziness, that the evidence is much stronger for Dilantin. And so they're way, way, way up in terms of practice in the United States, way, way, way over here. But it's a hill that they're willing to die on. In terms of the decision between Lovenox and sub-Q heparin, I don't know if anyone in this room really wants to die on that hill. And in sort of going along with the crowd, it seems as if the evidence favors the safety of Lovenox as opposed to sub-Q heparin. And certainly in these large studies, we're not seeing adverse outcomes from that. Another recent publication came out in JAMA. This was back in 2021, looking at prophylactic hypertonic in traumatic brain injury patients. So they actually used 20% drips, which is impressive. They did it for 48 hours. They were giving these patients 32 grams of salt via IV on a daily basis. And they managed to enroll, this is a French study, they managed to enroll 300 patients. What they did find was that doing this prophylactic hypertonic didn't improve outcomes. So running these drips on patients with potentially normal ICPs did not improve outcomes. So looking at this Glasgow outcome score at 6 months, doing the standard care, which is the Brain Trauma Foundation guidelines of only giving hypertonic or hyperosmolar therapy in patients with elevated ICP, had very, very similar outcomes to these patients that got continuous infusions. However, there were some very bad adverse events from prophylactic hypertonic. So we tend to think like, oh, I'll run 3% drip at 30 for a couple of days. It's no big deal. It's just 3%. But in these patients, they had much higher rates of DVT, and quite a few of them were pushed over 160. And those were pretty significant adverse events. Another recent publication was in rates of intracranial hypertension after primary craniectomy. So in these patients that we've decompressed, should we be worried about their ICP, or are they just fine? Should we just kind of keep an eye on them? And for patients with having had a decompressive craniectomy after trauma, 36% of them ended up with an elevated ICP. And that's really pretty similar to the numbers that you see for all comers with GCS less than 8. So having a decompressive craniectomy does not in any way exclude the possibility that they'll develop intracranial hypertension. So if they continue to follow the Brain Trauma Foundation guidelines, if their GCS is less than 8, get an ICP monitor. It doesn't have to be an EVD, it can be an ICP monitor. But assuming that because you've taken the bone off, that they're going to be fine probably is not going to lead to good outcomes. So the thing that I find very confusing about that is that you get with the scalp dissection, you get quite a bit of, firmness, that edema from the scalp dissection. So unless you're actually getting an ultrasound, and there's people that have proposed doing that, like measuring intracranial pressure in infants and people that have had a craniectomy with ultrasound, and that seems to be a technology being developed. But at this point, an ICP monitor is probably your friend. So I gave you a really tough opening question. A 40-year-old male, severe TBI, GCS 14 on arrival, one reactive pupil, large subdural, some lab values. After 7 days, he has normal flexion, eyes to pain. He's grade 3 DAI. What's his 2-year outcome? And it seemed to be that everyone thought that he was going to be a SNF resident. Does anyone have any ideas on how to predict the outcome of these patients? So there's two major models in severe TBI, the impact and crash model. If you Google it, under MD Calc, there's this impact model. It was written by this Eva Steyerberg. They have a nice little picture of him. Eva has an H index of 163. So he's published 163 papers with over 163 citations. He has over 1,000 papers. He's a very smart guy. Ava published this back in like 2007. The impact score for outcomes in head injury. It'll ask you how many pupils were reactive, the type of injury, the age, and then some lab values. And if we plug it in for the patient in the last slide, the impact score, they say a probability of a 6-month mortality of 54% and a probability of a 6-month unfavorable outcome, meaning SNF resident or worse, of 82%. So maybe even worse than what the consensus was. This was a paper that came out last fall in the Red Journal, and in the TBI community, this was a very, very big deal. At the CNS this year, this ended up getting the award for best paper in traumatic brain injury. It was a study out of Pitt looking at time to follow commands in severe TBI. And they were looking at survivors with favorable recovery at 2 years. Favorable recovery in TBI is either that they're able to live at home, able to be left alone for 8 hours or more, not necessarily complete return to work and things like that. But in traumatic brain injury, a favorable outcome is GOSE 4 or better. This was kind of a confusing study design. There was 508 patients. 229 were dead at 24 months. Again, like the subdural study, the vast majority of these patients died in the first 2 weeks. Of the alive patients at 24 months, they were able to get complete GOSE scores for 187. Only 47 of them had an unfavorable outcome. This was a shocking number, that roughly 2/3 had a favorable outcome at 2 years if they were still alive. And these are all severe TBIs. The other very strange and unexpected outcome was that there was a pretty significant portion of those patients with favorable outcomes who had upper moderate, which is, they're certainly able to live at home. They have some difficulties with work. But you know, may have a deficit in one particular area, like they're bad at socializing, bad at work, bad at home, but otherwise able to live independently. GUSD 7, 8. GUSD 7 is moderate difficulty in one domain, and then GCS 8 is essentially full recovery. So among the patients that were kept alive for 2 years, 22 had near complete recovery. This was a huge surprise. And in traumatic brain injury, the surprising thing that was seen in this paper is that comparing the 3-month outcomes in these patients to their 24-month, this group that had GUSD 5, which is at home, able to be left alone for more than 8 hours, but still needing significant help. At 3 months, quite a few of those patients were vegetative state, or not necessarily vegetative state, but definitely sniff.
Did they do a dropout analysis for the people with
They didn't, but I'll get back to that. In terms of the effects of different injury, peri-injury factors, DAI was a big factor. So in patients with a favorable outcome, the patients with DAI followed commands 9 days later than the subdural epidural group. And then infection was also a big factor. That patients that followed commands that well, had a favorable outcome, but had an infection with their original injury, followed commands 6 days later on average. So in this group of patients that GOSC 4 or better at 24 months, a third of patients with good outcomes at 24 months did not follow commands at 2 weeks. So if we use 2 weeks as our, they should be following commands by 2 weeks, otherwise they're going to have an unfavorable outcome, we're going to miss about a third of the group that ends up having a favorable outcome. So the first question, as we're bringing up, like, is this all a fluke? Is this just specific to PIT? Is this a result of all this fallout that the patients that didn't get complete GIC scores at 2 years didn't have full data? What I do is compare it to the subdural group, which I hope you burned in your head, that in this group, it almost perfectly mirrors among the alive patients the PIT results. That 2/3, so GOSC 4 or better, 2/3 of them ended up with GOSC 4 or better at 12 months. Among the patients that were kept alive past 2 weeks. So one thing that's probably changing in traumatic brain injuries that prognosticating early is probably, at least based on current data, is probably a little hasty. That we're going to end up having to give these patients more time if the family is willing to go along to potentially see whether or not they're going to improve. So some conclusions: prophylactic craniectomy, unfractionated versus craniotomy, unfractionated heparin versus Lovenox, prophylactic hypertonic versus usual care, probably not beneficial in TBI patients. TBI patients do have a significant risk of intracranial hypertension after craniectomy, and we need to consider that in those patients. Definitely prognosis in TBI patients is shifting quite a bit. Next month, I'm going to Rotterdam to meet Professor Steyerberg and his team. And the whole focus of that meeting is going to be on improving TBI prognostic models and updating them from the 2007 data and improving them. But at this point, saying for certain in a patient that you've only seen for 3 days that they're going to have a very, very bad outcome is probably hasty. And if the patients and their families are willing to give you some more runway, getting them through their acute illness and seeing if they start to improve might be worthwhile. Any questions?
For the patients who weren't following, is that 2 weeks, you said? Did they say on average for that third
So,
outcomes?
of the group that made it home, 1/3 of those patients were not following commands at 2 weeks. In the study, the maximum time to follow commands in a patient that made it home at 2 years, 87 days. I certainly would not advocate for waiting 87 days, but a little bit longer in these patients will hopefully capture more of these favorable outcome patients.
Your last statement concerning the outcomes in the
So in the PIT study, they didn't really find like a strong relationship to age, but in most of the models, like the impact model, age is like one of the biggest factors. So I have been sort of discussing this with the nurses, kind of what is my limits of, what are the patients that I'm going to tell the families, you are certainly going to have a bad outcome. I would say that brainstem only at a week, probably not going to have a good outcome. Secondary injury. So they come in with subdural and then with diffuse traumatic subarachnoid and develop vasospasm or strokes afterwards, not going to have a good outcome. That's going to be poor. Patients that, and that would also include like an intracranial abscess or something like that early on. Those patients don't have a very good outcome. I would also say that the patients that are compromised medically coming in, the ESRD, severe CAD, severe vascular path, dementia, those patients aren't going to have a good outcome. I don't yet know if giving like a cutoff, 75 and severe TBI, they most will not have a good outcome, but it's certainly lower. I would say that once you get like the super elderly though, 80, 85, then I don't really see good outcomes in those patients either. But like a 60-year-old, I think those ones were worth giving a shot. I'm supposed to measure whether or not you guys learned from the study or the presentation. So